Good morning, everyone. So today I'll be discussing about trigeminal neuralgia, which is most commonly encountered in the clinical aspect. So, so these are all the contents which I'll be covering about this topic. And when you see the definition of a pain, it's an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. So this is according to International Association Study of Pain. So, but when you come to trigeminal neuralgia, so this trigeminal neuralgia is defined by the same IASP as sudden, unilateral, severe, brief stabbing recurrent pains in the distribution of one or more branches of the fifth cranial. Okay, so this is the definition of a trigeminal neuralgia. So this trigeminal neuralgia is also called as Fothergill's disease because he is the one who reported this disease, and it's also called tic doulorex. So the pain comes in episodes, and also other name trifacial neuralgia. When you see the etiology of this trigeminal neuralgia, so most commonest cause is there is a compression of nerve bundle by any vascular factors, could be blood vessels. Okay, so any intracranial tumors causing the pressure effect on the nerve bundles, and any nerve demyelination and brainstem infarction, any of these factors which can cause this trigeminal neuralgia, giving rise to episodes of pain. When you see the pathophysiology, so any blood vessels which is having the atherosclerotic plaque, which can pressing on the root of the trigeminal neuralgia causes focal demyelination, and that will in turn leads to hyperexcitability of nerve fibers and giving rise to episodes of intense pain. So females are most commonly affected than the male, and fourth to fifth decade is the most commonly affected age. So the pain usually will have a one-sided pain and last for a few seconds to a few minutes, and the pain is like intense electric shock like pain, and right side is more affected than the left side. The most important point in this condition is between the attacks the patient will be asymptomatic, is totally normal. So during the attack the patient will have a severe electric shock like pain, and apart from this the patient will have triggering zones, and these zones can be on the face like skin of the upper lip, lower lip, nasolabial fold, half nose, cheeks, gums, etc. anywhere. Okay. So when you come to a diagnosis purpose in the clinical side, we follow this SWEET diagnostic criteria. So that is having the paroxysmal pain, that is episodes of pain which is coming, and in between the attacks the pain is not there. So pain is provoked by the trigger zones, touching the trigger zones giving rise to pain, and the pain is confined to the nerve distribution. It could be V1, V2, V3, maybe ophthalmic or maybe maxillary or mandibular. So this pain is confined to the nerve distribution area, and pain is usually one-sided, that is unilateral, and when you do clinical sensory examination, it is normal. Coming to investigation, first we'll go for a clinical examination, and next we'll give a diagnostic nerve block, and after that if you need, MR is the one which is giving much information than CT, and also you can go for magnetic resonance tomographic imaging. So that tells you the relation between nerve and blood vessels in the vicinity, and lately we can go for EEG and microneurography. And coming to the differential diagnosis, most differential diagnosis is glossopharyngeal neuralgia, post-herpetic neuralgia, and cracked tooth syndrome, and many more. So when you come to management of this trigeminal neuralgia, usually this is managed with a pharmacological approach, giving the medicines, and also we have surgical. Okay, so gabapentin, baclofen, and lamotrigine. So gabapentin, baclofen is usually given in the where it's not pain is not coming in control or not completely relieved with the carbamazepine, oxycarbamazepine. So you can club the carbamazepine along with the this gabapentin or baclofen. So when you come to surgical approach, so we have microvascular decompression of nerve and nerve sectioning and percutaneous rhizotomy and electrocoagulation of a gazetted ganglion. So these are the surgical approaches or modalities of for trigeminal neuralgia. I'm So when you come to managing these patients and diagnosing the patients, you should observe the best pathognomic signs we can say. Okay, so like unilateral pain is the most important thing, and electric shock like pain which comes in the episodes, so that you need to keep it in mind. And usually right side is the most commonly affected, and in between the attacks the patient is normal. And one more thing is triggering zones which are there in these patients. So keeping these points, you can diagnose this trigeminal neuralgia. And when you come to management, so we can manage with this condition with the carbamazepine very well, and you can give the carbamazepine up to the 1000 mg per day. And beyond that, if the pain is not getting controlled, then you can refer to the patient to the neurophysician and neurosurgeon for the better management. So thank you.